Hi, my name's Cecil Armstrong. I have Wegener's disease, or GPA, which is a vasculitis of the small blood vessels. This all started off with a cough that lasted for 18 months. I had multiple chest x-rays, nothing was visible. And I remember not long before I was diagnosed, I was in with my GP and I said, in the last 3 months, I've been in every month with something different wrong with me. In the last month, I've been in every week with something else wrong. What's going on? The key point in the whole journey was when I told a respiratory consultant that I could feel something moving in my chest when I jumped up and down. He ordered a CT scan. By the end, I had irregular heart rhythms, a continuous cough, night sweats, hoarseness, blocked eustachian tubes, terrible pains down the back of my legs, and was probably close to needing an emergency admission. I found afterwards that the CT, which cracked the whole problem, cost about 150 quid. But unfortunately, the NHS has had to spend a fortune on me since. So once we had the diagnosis, this chest CT showed areas of what the medics called consolidation in my lungs. So I was admitted to the Royal Victoria Hospital in Belfast for 1 week of intensive testing in 2014. Now, once I got the attention of the NHS, the quality of the care and the rigorousness of the investigation was hugely impressive. My diagnosis was finally confirmed by a kidney biopsy. In retrospect, there was a major physiological impact on me as well. I went from being a fit, healthy 62-year-old orienteer who could trot happily for an hour over mountains or through forests to a 63-year-old who couldn't walk 200 meters. So I thought I'd like to say a few things about what I see as the important characteristics of a vasculitis consultant. To me, the most important one is that I have to be able to trust him. When this weird stuff in my CT was identified, I was actually hugely relieved. I didn't care how bad the problem was, but as the consultant said, at least now we've got something to get our teeth into. My trust in the NHS was rebuilt very quickly by the 1 week hospital stay I had with all the testing. Every evening I was updated on what results had been obtained and what was planned for tomorrow. I remember one of the senior doctors saying to me, "It must be very frustrating to have not started treatment, but if we started treatment with the wrong diagnosis, then we'll set ourselves back a month." So I was then completely content that I was in good hands. It was finally agreed that Dr. Chris Hill of Nephrology in Belfast City Hospital would look after me. And we saw a lot of each other at clinics after I was discharged. The first time I wasn't seen by him personally, I remember having separation anxiety, like a dog that had been left at home on its own. But then I figured it probably meant he wasn't that worried about me, which was actually really good. A second important characteristic is that the doctor's prepared to listen. After my diagnosis of vasculitis, my wife and I had many unfounded worries that were easily dealt with. I was PR3 ANCA positive, which meant I was more likely to have a relapse. So, what happens then? And Dr. Hill says, "Don't worry, we'll just jump on it with the drugs." I also remember him saying to me, "I think we'll be sitting here in 10 years' time." And I ask, "How are you?" To which your reply will be, "I'm rightly." And in fact, so far, so good. Another important characteristic is to be honest and straight. I remember asking Dr. Hill, is it worthwhile redoing that chest CT to see what has happened to those areas of consolidation? To which his reply was, "Well, I don't know what we'll do about it if they are still there." And that contented me. I also remember saying to them, given that vasculitis is a rare disease, I can't expect you to be an expert. So how will we deal with complex problems? And to which, his reply was, well, we had the guy who leads the National Centre of Excellence in Edinburgh's Cambridge, Dr. Jane, over here a few months ago. If there's anything about your treatment or progress I'm not happy with, we'll be straight on him by email or consultation. Another thing is that because vasculitis is a multi-system disease, sometimes I've needed to an interface to other specialties. In my case, cardiology and rheumatology. It's hugely important when that Dr. Hill takes responsibility for making sure that happens. We're here at the Vasculitis Ireland Awareness Conference. I first discovered this organization through an acquaintance and went along to a meeting in Belfast, probably in 2015. Suddenly I was with these other people who had vasculitis, who had had many of the same experiences and who understood what was happening to me. I remember Julie Parr saying to me, you're only a year in, so it's still early days. I'll always be grateful to her for that reassurance. I'd just like to finish up with a final little story. Shortly after I went back to work part-time, I got into bed one night and put on my glasses to read before going to sleep. To my horror, I couldn't read properly, and my immediate reaction was, oh no, this blooming disease is now going for my eyes. The next morning, there was an email in work. Did anybody find a pair of glasses in meeting room 1? Thank you very much.
Good afternoon, everyone, or for me at the moment it's a Thursday evening, so good evening from my study in my house. I know it's a bit competitive these days when you see lots of webcam pictures as to the highbrow kind of books that are in the shelves in the background. Sadly, I don't go in for that, so if you were to look to my left, my other left, there's some Harry Potter books and some Star Wars Lego lying around the place, so don't hold that against me. I'm sorry I can't make it in person to the meeting, and I'd like to thank the organisers and Mr. Armstrong for inviting me. Sadly, the on-call schedule in the City Hospital has got in the way of it, so at the time that you're watching this, I will probably be middle of my weekend ward round on level 11. I hope you're all having a good time at the conference. I hope that what I'm going to talk about is interesting to you and useful to you. In a moment, I'm going to switch over just to a PowerPoint slide presentation. You'll hear my voice, but you won't be able to see my face, which is probably a bonus for you. And also, I'm not that tech savvy, so I can't work out how to put the video on as well. So without further ado, I'll move on to the PowerPoint presentation. Thank you once again for the invite. Good afternoon again, everyone. I hope this works okay. I'm going to give you a little bit about what I see as my perspective on vasculitis. If you've got a different doctor, a rheumatologist, a neurologist, a respiratory physician, they might give you a slightly different perspective, but I think we'd all roughly come up with the same things that we think are important. It's always good to have a plan. So the plan is that I'm going to very quickly run through 4 areas where I think awareness is important about vasculitis and where I think we can do better, if you like. So the first is making the diagnosis. It is a perennial problem, and I'll come on to why that is. I'll talk a little bit about the disease, its treatment, and its consequences. I'll talk about some multidisciplinary work and what we do now, what systems we have in place now, and where we might consider going in the future, and lastly, a little bit about the outlook for the future. And I think that's where the real potential positives are. So I tried to find some interesting quotes about vasculitis, but there really aren't any quotes from the great and the good of medicine. So I went right back to the beginning, and the father of modern medicine is this chap called Hippocrates, and he has some really good quotes which actually are pretty applicable to vasculitis. So firstly, about making the diagnosis, well, Hippocrates said about making any diagnosis to declare the past, diagnose the present, and foretell the future. And that's very true, because in vasculitis, persons may have had symptoms, sometimes quite vague symptoms, for months or even years prior to the diagnosis in the present. And then as a clinician, one of my jobs is to work out not just how the bits in the past get you to the point of the diagnosis, but also to foretell the future in terms of what treatments we're going to use and what the likely outcome from those treatments will be. So in terms of making the diagnosis, many of you probably watch medical shows. I used to love House with Hugh Laurie, and there was lots of bandying around a table about coming up with ideas. But the reality is that a lot of medicine is pattern recognition. It's for example, someone who comes into the hospital with shortness of breath and exertion, who can't lie flat because they feel too short of breath, they've got swelling in their ankles, they've got a previous history of perhaps a heart attack, and that's a classic history and presentation of heart failure. But it could be something else. But the most common thing is heart failure. And similarly, we talk about red flag symptoms. So people of a certain age group who present with a change in their bowel habit or bleeding from their rectum, that's a red flag symptom, and there are defined pathways which you would then move down to investigate those. Unfortunately, vasculitis isn't like that. There are a few, maybe not red flags, but things that could point out in a history that this doesn't feel right. But unfortunately, vasculitis can mimic so many other illnesses, from the fairly benign type of illness such as sinusitis, right through to it almost looking like a person has some form of cancer. And the problem is, because it can mimic those things, it can take a while to get a diagnosis, or you can end up going down the wrong track for a while and then having to pull it back again. So because it's a rare disease and because it can present in so many ways, it never surprises me, and I certainly don't blame other clinicians like primary care clinicians or other specialties who would not routinely see vasculitis as I would, that they don't get there on the first attempt. It's not a huge surprise, to be honest, but we need to be better. So how do we improve making the diagnosis? Well, it's not easy, and it will take time. It involves teaching. So at the moment, I do some work with Queen's University, and they'd already started to look at a new curriculum for the medical school which integrated students into specialties more closely and was designed to not just teach little silos of information, like this week you do nephrology, this week you do hematology, this week you do rheumatology, and you never really put it all together. Whereas the new curriculum is designed to integrate things more tightly, so that students don't just learn little packets of information, but start to think, well, hang on a minute, the person who we talked about earlier who's presenting with heart failure, are they really presenting with heart failure, or could they have kidney disease that's causing fluid retention that looks like heart failure? And that's an example of how we can change things. That effect will take time to come through, but it's worth doing. Postgraduate medical training also is important. So just because you graduate from medical school doesn't mean you stop learning. And in Northern Ireland, every junior doctor in their second year of work has to do a whole session on kidney disease, where we teach about causes of kidney disease, including vasculitis, to try to raise that awareness. We need to use our current information system better, and we are. So within the last few years, we've developed computer algorithms which can alert people when there's a change in kidney function. So if I request a blood test, let's say I'm not a kidney specialist, I just happen to be seeing a patient for the first time, the lab system will compare their kidney blood results this time to a result within the last 3 to 6 months, and if it's significantly different, will flag up an alert to me as the referring clinician that something's not right here. Obviously that only works for lab-based tests such as blood tests. It may not be as applicable to for example, joint disease or skin problems, but it's a start. And then there are new systems in the pipeline, and in particular one called Encompass, which I'll talk about a little bit later when I mention multidisciplinary management. So the disease itself, its treatment and its consequences. Good old Hippocrates said it is far more important to know what person the disease has than what disease the person has. I'm not certain that's completely true, but I think I know what he's getting at. It's about understanding that diseases present in different ways and affect people in different ways. And I would extend that to say that treatments affect people in different ways as well. And it's a fairly crude example, but I would suggest that as a consultant, the treatment that I would give to a 25-year-old otherwise fit and healthy person who presents with significant kidney disease due to vasculitis would potentially be more heavy duty than an 85-year-old person who perhaps is frail, who has other health problems, because I know that the more frail elderly person is more likely to get extensive side effects without perhaps getting quite so much benefit as the younger person. So the disease, it is often multi-system, and that's part of the reason why sometimes it's hard to diagnose, because people can have blocked sinuses, they can have ear problems, they can then get chest problems, but the sinus problems have gone, and then they present with kidney problems. And it's only when you put together that whole scenario that you realize what's actually going on. Of course, there are groups of persons who will only have primarily one organ or system involved, such as kidneys or lungs or skin. So it's a mixed bag. And as medics, we somewhat crudely classify it on the size of the blood vessel that's primarily affected, but clearly you have lots of different sizes of blood vessel, and you have blood vessels everywhere, so the diseases can often affect pretty much everywhere. And therefore, the disease severity can range from relatively mild, and I say that not to diminish the milder diseases, but simply to say that, for example, joint pain and arthritis can be an awfully debilitating illness, but it may not be as acutely life-threatening as, for example, severe kidney impairment or lung involvement, but still it always needs treated. And just to give you an example, this is the range of vasculitis disease that myself as a kidney doctor that I would come across. And in fact, probably looking at that, I've come across about at least 3/4 of the diseases listed on that diagram during my time as a consultant. The treatments then, I won't bore you with the details, but as a kidney doctor, the treatments that I would most commonly use for someone who presents for the first time with kidney impairment is either rituximab or cyclophosphamide. Rituximab is perhaps the newer drug, probably slightly cleaner drug in terms of side effect profile and certainly in terms of ease of administration. It has been around for maybe 10 years, but it's only within the last 2 to 3 years that we've been able to say with good research evidence that it's efficacious and as efficacious as the older drug cyclophosphamide listed below. Both of them have side effect profiles. They can increase infection risk and cause other side effects. And then the most commonly prescribed probably medications of all are steroid therapy, usually in the form of oral treatment with a drug called prednisolone. And I have to say, as a clinician, the steroids are the drugs that people struggle with most. They have the biggest side effect profile, and can be really hard on people, particularly in the early stages of treatment where the doses are very high sometimes. And then the medications on the bottom are perhaps less frequently used, but certainly are there if required. And I suppose the consequences of the disease and its treatment can be significant. There's a recovery period, and again, the duration of that recovery period really reflects how bad your original disease was. You know, if you have relatively limited skin involvement, that can resolve very quickly, within a matter of a couple of weeks sometimes, versus if you've had lung and kidney involvement simultaneously and have ended up in hospital on dialysis treatment, it can be weeks, months, and sometimes even years before people recover fully. And even if they do recover, there can, in some persons, be chronic, irreversible complications of the disease. For example, some persons who present with significant kidney impairment, even if you reverse some of it, may never get fully back to normal kidney function. Similarly, there can be chronic lung damage, chronic joint damage, and perhaps something which is under-recognized is the potential for psychological damage. A lot of persons who present with vasculitis may not have had any other significant illnesses in their life, and then suddenly they are hit with a sledgehammer of a diagnosis of a disease which can really cause major changes to their life. And I have to say, I think this is probably one of the areas that we're not brilliant at managing. I know Mr. Armstrong referred in his own sort of talk to the impact it had upon him, and I think he's not the only one. I've seen lots of people be hit very hard by this, and it can take some time. Across Northern Ireland, there is a shortage of clinical psychologists, and I think it's a real crucial area that we need to improve. And then lastly, the side effects of the treatment. Sometimes, particularly in the early stages of treatment, I will say to patients, you may feel a little bit worse for the first week or two before you start to feel better, and that's not an exaggeration. Sometimes patients can get infections, they can gain weight with the steroids, or get a high blood pressure, high blood sugars, or there's a list there, and to the point where sometimes my junior doctors somewhat laugh at me for the detail that I go into in the side effect profile. But I think if I were a patient, I would want to know all the options and want to really know what awaited me in the next few weeks and months. But it is worth it, because the bottom line is, whilst there are side effects to the treatment, the disease can and will be controlled by it in nearly every case. So it is worth doing, despite sometimes the severity, if you like, of the treatment. And it's important to realise that the treatment isn't just me as a kidney doctor making this decision. It involves not just a medication that suppresses your immune system. It involves getting you back on your feet again, making sure your nutrition's good, liaising with colleagues in other specialties. You also deal with vasculitis and the complications of that, chatting to experts in other parts of the country, and it involves the patient as well. They are part of the multidisciplinary team. If you don't have a patient on board, you'll never achieve anything. And again, going back to old Hippocrates, he said, the art is long, life is short, opportunity fleeting, experiment dangerous, and judgment difficult. And particularly that, there are two bits of that which I would focus on. First thing is the art is long, and by that he meant you cannot learn everything about medicine in your career. Somebody will always know something else which is useful, and judgment in certain diseases such as vasculitis can be difficult. Making the diagnosis, I've already talked about, making the right choice in terms of the treatment plan, equally so, if not more so. So I suppose, to take an example of the current patient journey, you might come and see me if you've had your diagnosis of vasculitis already. I'll see you in the City Hospital at your outpatient appointment here. A month later, you might see one of my colleagues in Musgrave Park Hospital in the rheumatology department. A couple of months after that, you might see a chest consultant in the Royal Victoria Hospital. And the result of all that, I think it's a confused patient, a patient who doesn't sometimes know who's directing treatment, what treatment they're on, what the plan is in the future for that treatment, and who do they contact if they have a problem. I also think it results in multiple appointments which really don't achieve very much in and of themselves, and in a situation where we are faced with a global pandemic, it's really quite difficult to justify that number of appointments if you're not changing treatment. So what's coming, or maybe what's around at the moment first, and then where we're heading to? Well, we have already got improved patient engagement in renal services through the use of this system called Patient View. So patients can look up their own blood tests after they've had them done. It gives them an opportunity to engage in, what is my kidney function? Am I getting any side effects from treatment? And it can lead to a healthy kind of give and take with consultants as well, which I think is really useful. I mean, I'm very happy to take queries from my patients at any stage, and I like to be challenged occasionally by them as well. And then in terms of, from a clinician's point of view, one of the big advances during my career has been the introduction of the Northern Ireland Electronic Care Record. It should be a matter of local pride to us that we have this brilliant system which collates information from lots of individual hospital systems. So for example, if I saw Mr. Joe Bloggs at clinic and typed in his hospital number into the electronic care record, it would pull all his lab data from the lab servers, it would pull recent clinic letters, it would pull radiology pictures. It is a fantastic resource, and it's miles ahead of anything they have in England, Scotland, or Wales. But it's not the end point. So this is the next step in delivering more integrated care in Northern Ireland. It's called Encompass. You can go to the NI Direct website and learn a lot more about it than I'll ever be able to tell you now. We're really excited by it as clinicians because it allows much faster acquisition of clinical data, much more integrated care between different specialties, and the ability for us to communicate more effectively with general practice as well. So it is a huge step forward, and hopefully once the COVID-19 situation is dealt with, will start to be rolled out in the next few years on a trust by trust basis. What do we still need though? Well, one could argue multidisciplinary clinics. So instead of going to see 3 different clinics, why not have myself as the nephrologist, the respiratory physician, and the rheumatologist all in one room at the one time? Well, clearly these days you can't all be in the one room at the one time due to social distancing, but you get the point. And that may be one option. Another option is just to improve the communication we've got. So why not have case conferences for difficult patients, have established pathways where people work together in small tight-knit groups? We've become so used now with COVID to doing Zoom conferences. Why do we feel the need to drag patients up to different appointments when we could all drag them up to one appointment, and then all 3 of us get onto Zoom or whatever system you want to use and talk about the results? And as I've mentioned already, the ongoing integration of healthcare IT systems within each hospital trust and also between different hospital trusts can only help to improve things. And then lastly, the outlook for the future. And I will admit, the quote on this one's a little bit of a stretch. That which is used develops, that which is not used wastes away. And I suppose I would focus on the first half of that statement, in that we use the resources that we've got, the research opportunities that we've got, and the engagement of our patients to continue to gradually improve not just the medications and treatments which are given, but also the systems that we use. So change is coming. Already in terms of treatments, we've had major research evidence in the last probably 12 months in terms of kidney vasculitis to suggest that reducing the use of steroids in terms of lower doses of steroids are as effective as the higher doses we used to use, and also result in less side effects for patients, which can only be a good thing. And also, we've pretty much eliminated a treatment which we previously thought was helpful based on the, if you like, the thoughts as to how vasculitis processes affect kidneys, but actually after many years of painstaking research has proven to not be helpful, and that's a treatment called plasma exchange or plasmapheresis. In theory, some of the vasculitis that we deal with is caused by abnormal antibodies, ANCA antibodies floating around the bloodstream, and the theory in plasmapheresis was, well, if you effectively put the blood through a filter and filter out those antibodies, it must be helpful. And indeed, there were some very old studies which suggested that might be the case. The problem with vasculitis is it's rare, and it takes a certain number of patients to be enrolled in a research study to actually get a meaningful result out of it. So this took years to put together, but it's worth it, because in the end it said, actually, you're doing a treatment here that doesn't help patients appreciably and may actually cause side effects. So why are you doing it? So as clinicians, it's important for us to always challenge ourselves. Just because I can do something doesn't mean that I should, and doesn't mean that it is the right thing for the patient. So these changes are already here. There are new treatments in the development pipeline. One I can think of is a drug called avacopan, and it potentially offers the possibility of completely steroid-free treatment, which would be an unheard of development in vasculitis. It's still in the early stages of treatment, and of development, I should say, and there are other new drugs coming out as well that are still in research. But it is an exciting time for clinicians in the treatment of vasculitis. And lastly, as I've already alluded to, we need to get better at integrating our services, working outside the silos of our various specialties in medicine, streamlining pathways to recognize disease, and if that's through better use of information technology, some kind of machine learning or almost artificial intelligence, so be it. It won't be a quick transition to that, but it is something we constantly need to strive to do. With that, I'm done. I'd like to thank you again for the opportunity to speak to you all today, and once again, my apologies that I can't do this live. Thank you.